Today we'll be doing the foot and ankle examination. The main pieces of our foot and ankle examination will be posture, functional test, observation clearing test, palpation, range of motion, strength testing, and special tests.
In this video, we'll focus on general observation and posture examination. Before we proceed to a full in-depth examination, we always assess our patient for any obvious deformity or malalignment. When examining a general posture, we can start either from head to toe or from toe all the way up to the head. We will examine our patient from front or anterior side, posteriorly, and from both sides. I'll start examining from head to toe and anteriorly. I focus on the position of the head and position of the jaw. If there is any symmetry or asymmetry of the jaw, then I proceed to shoulders and I examine the height or any height difference between the shoulders. I assess the muscle bulk in trapezius, deltoid, pectoral muscles. I observe the level of the clavicules on the both sides, if there is any height difference, and then I proceed to assess the upper limbs to see how they are rested in the rested position, if there is any difference in the carrying angle, any varus or valgus deformity of the elbows. I assess also the torso, if there is any asymmetry in the torso, what's the quality of the muscle, pectoralis muscle bulk, if there is any difference between the size of the gaps between the torso and each upper limb, which would point to any obvious scoliosis. Coming down from torso, we palpate and assess the position and level of ASIS to see if there is any level difference and height difference. We then proceed to assessing lower limbs. In lower limbs, we assess the muscle bulk on the thighs. Coming down to knees, we palpate and assess the level and the symmetry of the kneecaps or patella. If there is any height difference, if any of them is higher than the other one, or if there is any inward or outward rotation of the kneecap. We then assess the position of the tibia on both sides. Coming to assessing the feet, we assess the position of the feet, if there is any supination or pronation, or flattening or high arch of the foot, and also position of the toes. I can see that John's feet are slightly externally rotated. After I assess my patient from the anterior side, I start assessing my patient from the lateral side. For this assessment, I can use an imaginary plumb line, which is a line straight from the ceiling going through the external auditory meatus, through AC joint, crater trochanter, knee joint, and the medial lateral malleolus. In this position, I can assess if there is any obvious head tilt either forward or backwards, if there is any if the shoulders are rounded to the front, if there is any obvious kyphosis, if there is any obvious lordosis, if there is any obvious pelvic tilt, and also if there is any obvious hyperextension of the knees. Once done that, I can assess my patient from the posterior side. Here again, I'll start with assessing the position of the head, and the anatomical point in this position, or in this side, are the mastoid processes. Again, I palpate them and assess if they're at the same level, at the same height. Again, I'll assess the position and symmetry of the shoulders, muscle bulk. I proceed then to palpate and assess the level of both scapula. If there is any obvious scapular winging, inferior poles of the scapula. Again, what's the symmetry of the torso? Going down to the pelvis, I'll palpate the PSIS and assess the level and the symmetry of the position of the PSIS. Going down, I assess the muscle bulk of the gluteal muscles, gluteal crest. So as I go down, I assess the quality of the muscle bulk of the hamstring. I'll come down to the posterior part of the knee, which is a popliteal joint line. Again, assess the level and symmetry of the popliteal joint line. Moving downwards, I assess the quality of the muscle bulk of the calf muscles and the symmetry and quality of the Achilles tendons. Once completed this is going to be the piece information for my further examination.
And now we're moving to clearing test. For the foot and ankle, we're going to clear the joints above, which is the knee and also the lumbar spine. First, we're going to start with lumbar spine. We're going to ask the patient to touch her toes while keeping the knee straight. Can you please do that? Then we're just going to add some overpressure. Can you go up? Put your hands behind your back. Then can you extend all the way back? I'm also adding overpressure. Okay, relax. Put your hands toward the side. Then just slide toward the knee. Then adding overpressure. Can I do that to the other side? Adding overpressure. Now we're going to do a quadrant. So I want you to take your right hand, put it in your left back pocket, then just slide it down. Then I'm just going to add some overpressure. Can do the same for other side. Adding overpressure. Okay. What we're looking for is reproduction of symptoms in the foot and ankle. If there is any, we're going to do a full neurological assessment. Next, we're going to move into the knee. So can you just lay on your back? For the knee, we're doing a flexion and extension. So can you bring your heel towards your bottom? Then we're just going to add some overpressure. Can you extend all the way out? And we're going to add some overpressure. Here we're also looking for symptoms for in the knee or foot and ankle. If there is any pain in the knee, then we're going to assist the knee as well. And now we're looking at range of motion with the foot and ankle. Foot and ankle has 4 movements: plantar flexion, dorsiflexion, inversion, and eversion. First, we're going to start by doing plantar flexion. So can you just point it towards me, please? Then we're just going to add some overpressure. What we're looking at is 55 degrees of plantar flexion, 25 is functional. Then we're going to move into dorsiflexion. So can you just put your toes towards you? Then I'm just going to add some overpressure. So with the extended knee, we're looking at the gastrocnemius, but we can also test the soleus, which is going into 90 degrees of knee flexion. Then we're doing the same movement, and we can just also add overpressure. And we can also test the dorsiflexion by doing the knee to wall test. Then we're going to move into inversion and eversion. So inversion is 20 degrees, eversion is 10 degrees. So we're just going to tell the patient, can you touch your toes to my hand? Then I'm just going to add some overpressure as well. Other side, I'm also adding overpressure. Then we can check passively by stabilizing the calcaneus and also checking the foot range of motion. And also we can do that for the toes. So for the big toe, we can ask the patient the same. So can you just pull your toes toward you? Then I'm just going to add as well some overpressure. Usually it's 45 degrees for athletes. And we can also check the range of motion of the other toes as well. And also down. So now we're going to move into palpation. I'm going to start from the knee down. So first we're going to feel the tibia, which is the big bone right in the middle, which is like easily to find. And also the fibula. So this is the proximal head of fibula, and I'm going to trace it down all the way to the lateral malleolus, so the distal head of fibula. And right in the middle, between the tibia and the fibula, is our tibialis anterior muscle, and we can also check it for any tenderness or pain while palpating. And right behind the fibula is our peroneal muscles, so peroneal longus and brevis, which goes all the way down to the base of the 5th metatarsals. And from the medial side, we can also check the gastrocnemius muscle, the bulky muscle right here, and just underneath it, the soleus muscle, and also the Achilles tendon. Then we're just gonna straighten your leg, and just by going just underneath the tibia, we can also feel the joint line of the ankles right in the middle, and going laterally to the medial malleolus and the lateral malleolus. So these are going to be the guide for the next few palpations. So if we move into the medial malleolus and we just move just underneath it is our deltoid ligament. So just underneath the medial malleolus. Then right behind it is our Tom, Dick, and nervus hairy, which is the tibialis posterior tendon, flexor digitorum longus, tibial artery, tibial nerve, and flexor helix, just around it, just behind it. Then if we move into the lateral malleolus, and this is also going to be our guide for this palpation, just right in front of it, there's like a small gap. This is where we're going to feel the ATFL ligament, and just under it is our CFL ligament, and behind it is our posterior TFL ligament. Okay, then if we go back again to the middle, and we move under the joint line is our talus bone. So this bone, a big bone here in the middle. Then if we move to this side, to the medial side, this is our navicular bone. And if we move up a little, this is our navicular end spot, which we can feel if there is like a stress fracture by tapping on it. Then if we move down into the metatarsal, so that's the first metatarsal for the big toe, and we can move down, second, third, fourth, and fifth until we reach the fifth metatarsal, the base of the fifth metatarsal bone, and we can move into the phalangeas for this big toe, second, third, fourth, and fifth toe. We can also check the pulses for two arteries in the foot. One is right in the middle between metatarsals, so first and second one, which is the dorsalis pedis, just around this area, and we can check for the pulse. And also the posterior tibialis artery, which is, as we said, behind the medial malleolus, and we can also check for the pulse. And now we can move into the bottom of our foot, which we can find the heel fat pad, which is just underneath our calcaneum bone. And here we can find the origin of the plantar fascia, and we can track it all the way up to the first metatarsal bone, which we can find the sesamoid hallux, which is a circular bone that you can feel and you can roll your finger over it. And that concludes our palpation. So now we're going to move into strength testing. We're going to test both sides so we can compare between both of them to check for any asymmetries between the affected and unaffected leg. We're going to start by testing the unaffected leg. I'm going to do the dorsiflexion first. So can you just pull your toes towards you? I'm going to resist here. Then I'm going to check with the affected leg. Then I want you to push me down. I'm also going to check the other side. If both sides are symmetrical, we can do further assessment for the strength, and we can do a single leg heel raise. If the athlete wants to return to sport, it's ideal to get 25 more reps. So first we're going to start by heel raise with knee straight to test the gastrocnemius. Then we can repeat it again by doing it with knee bend to test the soleus muscle. So we want 25 more reps. Next we're going to move into inversion and eversion. So I'm going to do the same. I'm going to stabilize the tibia. Can you push in? Can you push in? Okay. Now we're going to move into eversion. So can you push me out? And also here, can you push me out? And that's for strength testing for plantar, dorsiflexion, inversion, and eversion. So now we're testing the ligaments around the ankle joint. First, we usually test the unaffected side to get the baseline laxity of the unaffected side, then move into the affected side. So first we're going to start by doing the anterior drawer test, which tests the ATFL ligament. It can be done in two different ways. The first one is just stabilizing the tibia and cupping the calcaneus. Then I'm just going to glide the foot forward or anterior and just checking for any laxity, pain, or reproduction of symptoms. Also, we can do it in a knee bend. So we're going to bend the knee. I'm going to stabilize the foot. Then I'm just going to push the tibia posteriorly. And we're also going to check for any pain, symptoms, or laxity. Next, we're going to test the CFL ligament, which is also from the lateral side. We're going to stabilize the tibia and the fibula. Then we're going to hold the foot and tilt it inward. This way we can test the CFL, and also you can check by tilting it to the inside. You can also check if there's a gap in the CFL to check if there's a tear. Then we're going to check. So this is the talar tilt. The lateral talar tilt is the opposite way. We're going to check the deltoid ligament. So it's going to be the same of stabilizing the tibia and fibula, but this time we're going to tilt the talus outward to check for any injuries in the deltoid ligament. So also reproduction of symptoms, pain, or laxity. Next, we're going to check the syndesmosis, which is a ligament between the tibia and the fibula, which can be injured in high-grade sprains. We're gonna start by doing the squeeze test. So we're gonna start squeezing the tibia and the fibula together, going proximal, so we can create that distal distraction between the tibia and the fibula, looking for any reproduction of symptoms or pain in the area. Next, we can move on to the fibula translation test. We're gonna push and glide the tibia posteriorly, also looking for any irritation or more movements in the fibula. Okay. And the last one is Kliger's test, which is applying dorsiflexion and external rotation, so forced dorsiflexion, external rotation, to also create movement in the fibula and check if there is any irritation. So dorsiflexion and external rotation, and we check for any reproduction of pain, symptoms, or excessive movement of the fibula. So just in comparison, this is how we do it. Okay, these are our ligament special tests. We can also check impingement in the ankle joint. There are two types of impingement, anterior and posterior. So impingement is a pathology in the joint line, and we can check the anterior impingement by doing forced dorsiflexion. So we're gonna hold the ankle joint and we're gonna move with speed and quickly to check for any blocking sensation, or sometimes maybe reproduction of pain or symptoms. So we're just gonna check for any blocking or something that forcefully stops you from doing the dorsiflexion. And we're moving with speed, so we don't just get the muscle length, but we wanna check the actual joint. The second one is the posterior impingement. Can you roll over, please? And slide down all the way. So we need the foot and ankle outside of the bed. So we're gonna do the same. I'm just gonna hold from around the calcaneus and have my thumbs in the heel pad. Then I'm gonna do the same. I'm just gonna go fast into posterior, into plantar flexion to check for posterior impingement. Then while the patient is in prone, we can also check for any Achilles injuries. So it can be tendinopathy or Achilles ruptures. So the Achilles is the long tendon that connects the calf muscle with your back of your heel. Injuries in the Achilles or ruptures can affect the active plantar flexion. So we can firstly palpate the Achilles. So we go all the way from the calf muscle all the way down and palpate the Achilles to check for any gaps in the muscle, in the tendon. So, and also there is the Thomas test, Thomas squeeze test, which is squeezing the calf muscle and looking at the foot if there is any movement. If the Achilles is ruptured, then the foot won't move. And we can also do it against gravity. So this one is with minimum gravity, and this one is with against gravity. I'm gonna do the same. I'm just gonna squeeze the calf muscle, and I'm looking at the foot if it's moving. The next couple of tests is gonna help us find any neurological symptoms around the foot and ankle. So the first test is gonna be the tunnel stop test. So first we're gonna find the medial malleolus, and we're gonna go just behind it, posterior to it. We're gonna find the tarsal tunnel, and we're gonna tap into the tibial nerve. So we're just gonna tap and check for any reproduction of symptoms. Then from here, we can also compress, and we're gonna do the triple compression test. So we're gonna compress the nerve, then we're gonna take the foot and ankle into plantar flexion with inversion. Then we're gonna take the hip into flexion. We're gonna hold it here for 30 seconds, also to check for any reproduction of symptoms. And next, we're gonna move on into Morton's neuroma, which is a nerve irritation between the second and the third toe. So we can check here for any irritation of the nerve, and we can do the Mulder's click. We're gonna create that dome and C shape, and we're gonna compress the foot, looking for any clicking or reproduction of symptoms.